Very good. So you can just Google clinicaltrials.gov, and what I wanted to show you is that this is an excellent place to go to find studies that are actually now recruiting for patients for whatever. For instance, you can search atypical HUS, you could search TMA, you could search eculizumab, you could search any drug that you might have heard about that you want to think about, could they be used? You would be able to find whether there is actually a trial. And so this site actually, by the way, and I wanted to show you this because someone asked me, it's not just the US. This is going to have trials that are going on in other countries too. Of course, it is primarily a US-based site, if you will, but it right now covers all 50 states and then 193 countries. So you can find actually some of the trials that might be going on. Just Google it. I think you'll find it. So what this session is actually, I did that for you. I Googled it for you, and I actually pulled up what we know is potentially coming out and what trials. If you Google either eculizumab or atypical HUS or complement treatment, this is what you're going to come up with. And it's not a lot. Which is probably to a degree a testament to eculizumab, but also the fact that we're not ready for the next generation of whatever it is yet. So speaking of the next generation, how's this? This is pretty amazing, and this is from Dr. Ricklin, who is a gentleman from Penn, who is not in Penn right now. Richard might know where he went to, but it's somewhere, I think actually in Basel maybe. But anyway, I wanted to show you this because if you look all the way, a couple years ago, we wouldn't have been able to say, these are all anti-complement drugs. Every one of them. So this is really cool because this would not have been happening years ago. So, but up here in the top side, if you will, is the list. And you can see eculizumab in there. I don't know, where is eculizumab? Anyway, eculizumab, 16, right. So eculizumab is right there. Binds C5, blocks the cleavage of C5, as you guys know. But there's a bunch of other meds up there that are anti-complement meds. Now, I will tell you straight up that these are not meant for patients with atypical HUS in general. These are probably meant for the other complement diseases that you guys might have heard about, that Richard maybe mentioned about the C3 glomerulopathies and things like that. But I want you to know that, keep your eye on some of those because they may in fact be useful at some point for some patients with atypical HUS, depending on what your variety of atypical HUS is. And again, there's the reference so that you can, this was an entire review, if you will, of complement therapeutics. So it was actually a pretty interesting manuscript. If anybody wants a copy of it, just let me know and I'll see if I can pull one down for you. But a bunch of drugs. So what I did is I went to clinicaltrials.gov and I pulled up actually what was available. And the first one is this CCX16A. And it is a C5a receptor antagonist. And so what that means, it's not C5b receptor, it's C5a receptor antagonist. So in those patients who make a lot of C5a, this in theory will help sop it up, and you will get less of the inflammation that you in theory would get by having lots of C5a floating around. Turns out that this group is actually offering a phased or recruiting for a phase 2 study to assess the effect of C5a receptor antagonists ex vivo, so outside of the body, if you will, for thrombus formation in diseases such as atypical HUS. So this is not terribly useful to you because what they're really doing is trying to figure out whether the C5a plays a role in atypical HUS. But again, in the interest of just sort of being complete, I thought I would bring this one to you. Then we have the next trial that was listed on clinicaltrials.gov is that French study that we talked about a little bit this morning with respect to cessation of drugs. So this is actually being advertised by them. It includes 31 sites where they are recruiting patients who actually are interested in undergoing discontinuation of the eculizumab. They have to have had remission for at least 6 months or 3 months if it's an MCP. They have to have, be non-pregnant or not planning pregnancy. They don't want them to be not covered by eculizumab and then get pregnant and have that pregnancy be the trigger for the atypical HUS. They also are not looking at anyone less than 3 years of age. And that's, that again is, as we sort of talked a little bit about this morning, banding about, whether you want to challenge these youngest patients with a risk of relapsing disease, knowing that they've got a lot of years to grow in these kidneys. So, and then finally, they have to have had normal renal function for at least 6 months, or normal and or stable renal function for at least 6 months. So this is another trial that is not a drug-related trial. It is a recruitment trial to try to figure out this issue about whether you can actually stop eculizumab. Then there is this one, which is the Atypical US Registry, and it's an observational, non-interventional, multi-center, multinational study of patients with atypical HUS. You guys know about this one. This is actually the one that is being sponsored by Alexion, so you guys are aware that this one exists and that they are in fact recruiting lots of patients. In theory, this one is an excellent place to actually begin to answer some of the questions that were talked about this morning in terms of if we collect enough patients who have X, Y, or Z, whether it's a certain mutation or a certain presentation or, whether it's having come off drug, whatever it is. We don't happen to be part of the Alexion registry here at Iowa, but there are many of your centers, even in the overseas setting, actually, who can help anybody actually get access to that. Not moving. Again, this session is going to be pretty short for us anyway, guys. So then the next one is that, which is probably the only one that it might be of value or of interest to many of you, is the one called for Alexion 1210. You've probably heard about it. I've heard a number of you here in the room say that you've even gotten phone calls about it. But Alexion 1210 is their product, which we believe is, or they believe is going to be the one that lasts for 4 weeks instead of the Q2 week or the every 2 weeks like what you all are doing right now, many of you are doing. I wanted to share this one with you because there were people that had actually sent in the question, is it coming, when is it coming, that sort of thing. It is right now on clinicaltrials.gov. It says, quote unquote, not yet recruiting, and I know this for sure. They have identified all of their sites that they are going to be recruiting from in theory, but they just haven't hit the button to begin the process. A couple of important things. You have to be older than 12 years of age. You have to have a clear thrombotic microangiopathy diagnosis. You have to have a current meningococcal vaccine, and it didn't say on the website whether it had to be the original Menactra, I guess what most of you will call it, or the Bexsero. It didn't say one, other, both, or not, but I'm sure that's a clarification you could seek later. And then you have to be, if you're of childbearing age, you have to be willing to use contraception, again, because they do not want you pregnant during the trial. And then some exclusions are kind of important. You have to have the Adams TS13 that is, and there's a typo there. Well, no, actually that's correct. Adams TS13 less than 5%, so you have to have a good chance that you're not TTP. You have to be Shiga toxin negative, so if you're positive, you're excluded. You can't have strep pneumoniae, HUS. I don't know if any of you know anybody or are a part of that. You can't be pregnant. You can't have a suspected drug exposure that is known to cause atypical HUS or thrombotic microangiopathy in the generic sense, meaning, noxicodone, none of the chemotherapies, etc. No bone marrow transplant, no rheumatologic disease, no chronic dialysis, and what I didn't list up there that I probably should have focused in a little bit more on is that you can't be on eculizumab. And that they are not currently for this allowing, yeah, exactly. That was the punchline, wasn't it? They really are looking for naive, eculizumab naive patients. So they're looking for new diagnoses. And I'm not part of that inner circle, so I don't know exactly why, but I would suspect it's for 2. They want to know that the new drug does just as well as eculizumab, so they don't want to be, sort of continuing, if you will. The second thing is that they probably, whoever whoever is diagnosed right now probably gets diagnosed much faster. Probably, I think you guys would agree with that. So a faster diagnosis is what they're really wanting. You know, they don't really want someone who's had a long delay in being diagnosed and then being brought into the trial. So, but anyway, that is listed on clinicaltrials.gov. You would be able to pull it up. You would be able to find out when they begin recruiting if there isn't a site near you. Again, most of you probably are not eligible for it, but it may very well be that those of you, if there's anybody in here waiting for a transplant, that you, of course, would be. You know, actually, now that I say that, they didn't technically say no transplant patients. So what I don't know is if someone is off eculizumab right now, and then you get your transplant and you need to start on the medication, whether that would be an allowed thing or not, I'm not sure. You can find out, I'm sure, by asking somebody. Sorry, where's... I'm sorry, where are you? Hold your hand up, I'm sorry. Okay, go ahead.
Why no rheumatological disease?
Why no neurologic disease? Oh, no rheumatologic, because what they don't want, and they actually did this in the first trial, they do not want lupus patients, for instance. And so what they don't, yeah. Yeah, so they're not going to, whether they are specifically excluding rheumatoid arthritis, or, they are excluding lupus, they are excluding scleroderma. They have a list of rheumatologic diseases that they are excluding, and actually they did that in the first trial too. Because there's still a lot of people that believe that these diseases are a secondary cause of TMA, and perhaps they don't need anti-complement therapy. They don't want to struggle with that battle. They don't even want to go to that, if you will. So they just have it as part of their exclusion criteria. That's what I presume.
Going back to one of the other slides, can you define what remission is?
You know, I'm not recalling that they actually said, but I'm going to guess that the presumption is that they have had you have normal platelets, you have an LDH that's less than 2 times the normal limit, you know, because that's their usual. Let me just say, we'll do it the reverse of what they said your inclusion criteria was for the previous trial. So it does mean that you need a low LDH, a normal platelet, and I don't know if there's a hemoglobin requirement in there. But again, these are things that you can actually find out by going to clinicaltrials.gov. If it's not listed there specifically, then there is always a contact person listed on those sites. So you would be able to find out the information by just emailing the contact or phoning the contact. So you'd be able to do that. So one more, I think I only have one more for you. So this is OMS 721. You guys, this has actually been out there a little while yet, and they are still recruiting. This is actually an anti-lectin pathway chemical. I don't know if it's I don't think it's a biologic. I think it's actually a molecule, if you will. But they're looking for patients that are greater than 18 years of age. They have primary atypical HUS. They could have bone marrow associated TMA, or they could actually have TTP in this trial. So they're accepting a much more heterogeneous group of patients to going in. They cannot have it's a little bit of a conflict there, but they cannot have a clinically apparent, this is a direct quote, clinically apparent alternative explanation for HUS and anemia. So other than those 3 things, there can't be another better reason, if you will, for that TMA. And then the only exclusions are you're probably not surprised, they don't want eculizumab patients or recent eculizumab patients. They don't want you to have typical HUS or having had STEC HUS. They don't want you to have a positive direct Coombs, because again, that's immune-mediated hemolysis, and we're not classically thinking about anti-complement therapy in that setting. And then they also don't want you to have active infection. So that trial is actually, I don't know the update on that one. Sometimes in the background we hear a little bit more about these trials, but I don't have any idea about this one to let you know what's going on. So that's really the most of what we have. I wanted to go back to this slide for just a second because I want again to highlight the fact that you know, there are more upstream blockers that might one day be useful in the atypical HUS setting. And so I'm very happy that all of these are being looked at, if you will. But None of them have requested a trial for atypical HUS. That's what the point of this is, to let you know that even though there might be a lot of things out there right now, to my knowledge, none of them have required to move forward for testing in our disease here. So we're not there yet, if you will. I mean, it's not something that you want to necessarily be trying out if they're not even ready to do a formal trial, because that's really what you need. You need a formal trial. You need something that allows you to know whether the response to whatever it is better than placebo or better than a control of some kind. Better than eculizumab, frankly. You need to know that whatever is going to be out there. You know, and again, some of these agents, you know, that are up there in that box, they're by mouth. Some of them are subcutaneous injections, a lot like what erythropoietin would have been, et cetera. So, you know, those are attractive elements if they do in fact block the complement like you would want it to be blocked in the setting of atypical HUS. But keep in mind, the upstream blockers may not necessarily help someone who has a problem down here at the surface level where a lot of atypical HUS is. So, and I think that's actually the last of what I had. So I'll take questions if anybody has them. Yes?
I'm not sure if I'm asking the right question, but I read about this technology. It's called CRISPR-Cas9. So for the atypical HUS that has associated with a genetic mutation, do you see an application for that technology to be able to edit that mistake?
Is the genetics team in here? Yes. Do you want to talk about CRISPR? If I do, it won't be as good.
A suitable therapy strategy for HUS. No. Short answer is no, it's not.
The short answer is no. I paraphrased. There you go. The issue would be is that for every, Boo, please fix this if I say this incorrectly, but for every single patient, you would have to go after that one single base change. So that would be the ultimate in personalized medicine, right? And you would have to get it into a cell that then repopulates the entire body in the fixed fashion, if you will.
Right.
So it can get really complicated. I do think it's a bit of science fiction that we should be thinking about, you know what I mean? That we should be moving towards maybe someday, but it's not ready for prime time yet. Is that fair?
Yeah, so another thing is the HS is such a complex disease. It's not just
Good point.
one single gene or one mutation that causes the disease. It's more likely to have multiple genes. And right now, people using CRISPR-Cas9 focus on those like single variants. They correct one single variant to cure those rare disease. But for the HUS, it's hard to find such target. So I would say in near future, this technology won't be used for HUS.
Yeah, right. So not in the near future, but
Long term, we don't know.
long time, yeah, we don't know. And the issue is, I didn't make this point, and that's exactly correct. So many patients, we still have a little bit of the undone issue that some patients, the connection to the gene mutation and their actual disease is hard to make directly. I mean, if someone has a huge piece of factor H that's missing, that's pretty clear because you can find out that they don't have factor H floating around in their bloodstream, et cetera. But, and those are the people that often the relative, if you will, doesn't have the disease because they don't have the same mutation, if you will. But it's hard to think about replacing that factor H mutation in that individual. If a parent has the same mutation and doesn't have disease, that gets to the issue about the multifactorial nature. Let's say you do go through the CRISPR process, which for those of you who want to know, CRISPR basically is fixing the DNA. So let's say you do go through the CRISPR process for this patient. I think right now what we know about atypical HUS, that's not a foregone conclusion that going through that process then eliminates disease in that patient. It's still, and I actually didn't think to say it that way, that's exactly right. It's still considered multifactorial disease. So you need to be able to CRISPR multifactorial things, and identifying those multifactorials is the problem. Yes?
Do you guys collaborate with other specialists within the university? Specifically, I used to work with retina specialists, and they were looking at using steroids for geographic atrophy for dry macular degeneration. And then I was recently at a conference for retinitis pigmentosa, and actually a researcher from here presented on their CRISPR technology, and I told him I was coming here for this meeting, and he said there's a lot of similarities between atypical HUS and some retinal diseases. So I don't know if there's
Yeah, we don't have a lot of meetings, if you will, with other specialties, but we're absolutely available for the discussion. We do have some discussions with them, but again, the eye changes are probably, well, the short answer is no. We don't have any clear relationship with them. We do know that, I personally know there are other people here on campus that are using Solaris for things like this, exactly. But the CRISPR, we haven't communicated on the CRISPR issue at all. Yes, please.
So, blocking it at the C5 level is, so to speak, at the base of the tree, so it blocks everything. Is there any advantage to moving up? Or you just be more selective if you move up? And are there any drugs that are targeting upstream further?
Yeah, it's not clear to me in atypical HUS that moving up is a good idea, but if it, yes, there are drugs that are coming out that are upstream by moving up, and so what I'm talking about is, you know, if you might remember Richard's picture of the C3 convertase, so right there in the middle where you have the C3BBB, if you blocked that, could you eliminate the amount of C5 and C5a that's being made? Absolutely, you could. We don't know that for sure yet, but that's obviously what they're expecting is that we may, for instance, those of you who have a low C3 because of your gene mutation or because of your, you know, whatever your cause of your atypical HUS is, in theory, blocking upstream at the convertase could cause your C3 to go normal. That is something that eculizumab will never be able to do, cause your C3 to go normal, for instance. But blocking upstream where you're chewing up less C3 could potentially help. The problem, the only reason I'm waffling a little bit is that we're not completely sure that, let's say if you have a factor H mutation and factor H does bind that C3 convertase, for instance, we're not 100% sure if we bind that C3 convertase instead of C5, if we have the same effect at the level of the endothelium. We might. We're not sure.
It's been standard, prior to starting Solaris to get the meningitis vaccine. And now there's the meningitis B one that's come out. I've heard different things about whether it's recommended or not. We wound up getting it done. I talked to, a doctor who wasn't ours, but do you recommend the meningitis B?
Yeah, so the question is do we as a practice recommend the meningitis B? For us it's called Bexsero, for you it might be have a different name, and we absolutely do, because for instance you probably know that if you get the older Menactra, which is very good because it covers it covers a number of the meningococcal strains, it does not cover B. So even if you got the Menactra and you got your booster doses, so on and so forth, you are not immunized for B meningococcus, and depending on where you are in the world, B may be the more common meningococcal strain. So we absolutely do recommend the Menactra, or the older version, and the Bexsero, the B version. We don't recommend it acutely because it's very inflaming for some people. So we do prefer that you be well blocked on your eculizumab before you actually get the Bexsero. So 1 or 2 doses. But there was another piece of caution I want to offer, though. There was a study that was actually done by Novartis. It's actually on clinicaltrials.gov, where they actually tested the patients who were actually given this B vaccine, and there were some strains of the B vaccine that were only 68. Did the patient develop immunity only 68% of the time? So even getting the new vaccine is not perfect. It's better, but it's not perfect.
What about boosters for meningitis?
What about what?
Boosters for that vaccine?
I still didn't hear that.
Boosters.
Boosters. Yes, I believe both manufacturers have recommendations for boosters. Monica, do you remember?
The Bexsero is two shots, 3 months apart, I believe, and Tremenda is the other Men B vaccine, and that is a 3 series.
Yeah, so there are programmed in boosters that are recommended actually even by package insert. So we do. And again, we just don't give the Bexsero acutely because we worry we're going to turn on a complement system that we would rather keep quiet for a little bit longer.
Will that become part of the, when you're starting up? Or you're saying you have to have Soliris before you get this?
Other places give it right away. That's just our habit, that we give them Menactra, and then we wait until after 2 doses of the eculizumab, and then we give the Bexsero. Other places will do them both at the same time, and it's fine. That's an idiosyncrasy of our program potentially, so I wouldn't stick to that.
That's still early on, like ours was years later because it didn't come out until years later.
Right.
But it's a standard practice now.
I think many patients, well, it's standard practice for us. So I mean,
Well, you're the gold standard, so.
yeah.
So, when you're talking about the 68% for the second B vaccine, is that because some people generally, they don't keep their titers as long anyway? Because there's been a couple of vaccines we've had to redo on him. So is that part of
Yeah,
the 68%?
Yeah, so why wouldn't you have better than a 68% when you got a vaccine? We're not 100% sure, but Dr. Thomas mentioned it a little bit. Patients with people with renal disease seem to not always respond to vaccines. I don't know, for instance, when you needed to get the B vaccine, for instance, that's often one of the ones we have to give again and again and again. Sometimes we just give up in our kidney patients because they don't respond. So there might be something underlying about the immune system in a patient who has kidney disease that keeps them from responding. But it may very well be that something about some of these manufactured immunizations, maybe they just aren't suitable for some patients. And possibly you can give it again and again and get the titer up to where it needs to be. But I also should give the caution. We don't have 100% certain, so in case you all wanted to go out and just get your titer done, we don't know exactly what a titer you need, and we don't know if your titer is really low. It is still possible, meaning it's sub-therapeutic potentially, it's still possible that if you actually got exposed to meningococcus B, that you would mount a response. We don't even know that answer. So I'm just saying that if you get a vaccine, you still have to be a little bit cautious about, that's not 100% protection from anything.
But when you give eculizumab, your complement system has been blocked. Does any vaccine have any use then?
Yes, because in general, the vaccines require your cellular response in order to make the antibodies that you need. They don't, it's an excellent question. They don't require your complement system to make the immune response. So for instance, all of our patients that had been immunized with Menactra or the other vaccine, as soon as Bexsero became available to us, we immunized them. And so we have a couple of patients who've been on for a long time, but we still immunize them because we presumed that they could respond.
Okay, what's your take on live vaccines like chickenpox?
We still don't, but I don't know that I have evidence for that. In fact, I'm sure I don't have evidence for that. And it's particularly bad for kids, obviously. When in your youngest patients, to say that you're not giving vaccines to your youngest patients is a little scary to me.
Or adults who have never been exposed to chickenpox.
Yeah.
That's the thing.
Yeah. We still follow the rule of not using live vaccines, but I will say that our ID people are not worried about it. So, but I am.
So I understand we're still a little ways off of having new treatment options for atypical HUS, but if you can fast forward once we have FDA approval for additional therapies, what would it look like? Like which patients would you consider switching to the new therapy? Like how would that switch occur, or who would you consider switching, who would you consider not?
So how do we choose the new therapies? And I'm not sure I have a good answer for that because, the reason we like eculizumab so much is because it's a great terminal complement blocker. And that, again, we deal with a couple of different complement diseases. And so we think of atypical HUS to be the classic terminal complement disease, whereas some of the other diseases we deal with are not. They're middle of the complement pathway diseases. And So where I'm going with that is that it seems like eculizumab's the perfect drug, frankly. Now, what would make it more perfect would be by mouth or once a year. I don't know. But I mean, something that is not an IV delivery. So I have a hard time actually thinking what would be the next best choice without the data. I would like to think that a by mouth, like I'll give you an example, and this was in the news just recently. There is coming out a drug, an anti-D drug, and in theory, if you can't use D, if you don't have D, you can't make that convertase, that middle guy. If you can't make the convertase, you shouldn't be able to make C5b, in theory. It's a by-mouth medication. So I would love to see if they're interested in trialing that in atypical HUS. I don't know if they're even interested. I'm just saying this is what I know from the news. This isn't because I know anything in the background, but I would be just a little bit suspicious without the trial data because, again, that's fluid phase dysregulation of the complement system, not cell phase regulation of the complement system, so it might not work. And you wouldn't want to select one of your atypical HUS patients who's had difficulty, who is going to be remaining on drug, and put them on something that you're not really sure is going to work. So that's a long-winded way of saying I'm not sure if I have a good guess about what should be next. But I do think over the next 2, 3, 4, maybe 5 years, we will have a much better handle on that.
To go back to the vaccines, I understand about the live versus killed. But some children get a series, some pediatricians give a series of shots at once. They'll give 3 or 4 shots. And then there's the whole vaccine for the 10-year-olds or so, which is the HPV. And, there's that whole, is that really needed, or is that something that you...
Well, we definitely recommend getting all the vaccines that you can, whether you're a child or adult, and we do that because the disease itself would be very complement activating. So anything you can prevent yourself from getting is a very good thing. The only thing about the live vaccines is, and again, I don't think that there's good data for this, but the only thing about live vaccines is you worry about the live vaccines they're more complement activating than dead vaccines but also they're more likely to cause mini disease, if you will, and it's just something that
Even if they want to give you 3 killed, dead vaccines.
Yeah, we still encourage vaccines. From my standpoint, it's a personal. If you're complement blocked, it's a personal preference whether you want to subject yourself to 3 vaccines at the same time or not. But yeah.
When you say no live vaccines, is it for all aHUS patients or just transplant? Because I know for transplant we don't have live vaccines.
Yeah.
But we got everything done before that we could, like they bumped
Yeah.
stuff up before the transplant.
Right now we're doing it for all, but you are 100% correct. We are actively talking about this, and we're trying to figure out for the for the native kidney atypical HUS, it probably will fall by the wayside eventually. For the transplants, it's different because you're not only on anti-complement therapy, but you're on at least 2 anticellular therapies, and so your risk for getting disease is much higher in that setting. We just haven't moved off of that yet in the native kidney patients, but we probably need to. No. No, I don't. That actually, frankly, as you've already sort of indicated, it's not because of the eculizumab, it's because of the other drugs. So, that'll stay put, I'm pretty sure.
At what age do you suggest a child get the HPV
Yeah.
vaccine? Her pediatrician said not till 15, but if she's on Soliris, shouldn't she get it? She's 11. She just turned 11.
Yeah, that's, I generally will follow the American Academy of Pediatrics recommendation, and there's a huge window in there. I think, I don't know, Monica, if you happen to know. I don't know I'm perfectly fine with the whole range, frankly. This is a difficult topic sometimes, but what you absolutely want is for the HPV to have gotten into your child before they become sexually active. That's really the cut point, if you will. Because the risk is sexual activity and being exposed to the HPV. And so you technically don't have to have them vaccinated if they're never going to become sexually active, but Do you hear that, Sam?
It's a perfect segue into my question.
Yeah.
So my question is, I've heard different opinions about the use of birth control, especially oral contraceptives, as being possible triggers for AHUS.
Yeah.
What are your thoughts? What is the latest research?
Yeah. So what the question was is, what about birth control in the development of a thrombotic microangiopathy? Let me preface it by saying I am a firm believer that there are drugs that can cause thrombotic microangiopathy, and they do not have to be patients with atypical HUS. You know, so I am a firm believer that there are things like that. I do not happen to believe birth control is one of them. And you know, this gets into that area of expert opinion, but I've read the cases that are out there, and I actually have a patient who was 43, who had been completely well her entire life. She started birth control in January. In March, she had her first atypical HUS episode. So of course, the assumption is that her birth control was actually the trigger. What we discovered years later was that she has a variant of unknown significant factor in C3. Now, it's a VUS though. I told you the problem with that. I don't know. I mean, I can't tell you for sure that that VUS caused, but I am natured to believe that the C3 is more likely to have caused her TMA than the birth control pills did, because there isn't a clear black and white mechanism for how that could happen. What I like about understanding of some of the drugs, I'll give you an example. I don't know, you guys probably don't inject oxycodone very often, but if you inject oxycodone, it turns out that the coating on that tablet that you just crushed up and put in water and then injected in you, hands down in a mouse model, in anybody you ever gave it to, it will cause a thrombotic microangiopathy. So for that, I have a clear mechanism. It's a chemical reaction at the level of the endothelium that causes TMA. So, you know, when I put my scientific hat on, I say, that's good because that's black and white. I can see what that connection is. I struggle with the connection with birth control pills. Now, that is my opinion though. That's my read of the literature. I absolutely know people who say, I've got an atypical HUS patient, I'm not putting them on birth control pills because I'm not taking the chance. I look at it on the other side. I do not want my atypical HUS patient getting pregnant without knowing about it or without, you know, sort of making a plan for it. So everything we do or every way we think about this is a plus minus, and that is definitely in the category of expert opinion or, you know, my read of the literature. Like I said, for oxycodone, I'm cool with that because I know exactly what that mechanism is. But you know, there's VEGF inhibitors. There's other things that I'm comfortable with saying that drug has caused it, but that's not one of them.
Are we all supposed to avoid oral or IV oxycodone?
No. It's specifically injected.
Okay.
Just don't be injecting it. Say it again. Back to the live vaccine. Shingles. I'm not sure if it is or not, to be honest with you. Is it? Monica knows. Thank you, Monica.
I can't find a doctor that will give me the shingles vaccine. I just got over shingles.
You know, I think we're going to have more of these answers soon. You know, it's probably just being overly cautious that we're doing this, you know, to be honest with you. But I think that again, it gets into that category of doing no harm. You know, we all have had patients who have gotten small cases of disease from having gotten a live vaccine, and if your immune system is healthy and your complement system is healthy, you probably fight those things off just fine, but we're just worried about it. But that might go by the wayside pretty soon, I'm not sure.
Has there been any experience with meningitis cases with someone at a do they take them off of it if it happens? I know it's a canceling.
Yes, I can give you personal experience. I have one patient that's exactly what happened. There probably are cases, but I have one patient who actually had, she has an MCP variant. She Dr. Thomas also mentioned to you that we actually we do prophylaxis here. So we do not only the immunization, but then we also do the antibiotic prophylaxis. This was a student who was not particularly interested in taking her prophylaxis. She got fever one weekend. We sent her to the emergency room as our protocol. She goes to the emergency room. She got her blood cultures drawn. She actually went home. That, you know, they said, yep, you've got a viral illness, go home. They called her, was it the next day? They called her the next day to tell her that her blood cultures were positive for meningococcus. And so she actually got taken off of eculizumab at that point. Now, she was one of those patients that actually had been treated well. She was at the baseline kidney function. She was doing very well on all parameters. You know, you've sort of seen the hint that in general, for young people, MCP mutations are probably not the worst of the worst. And at that point, she had to come off, she came off of the eculizumab, you know, for the blood infection. But then the family decision was to not go back on again, and we supported that.
What is it about meningitis particularly that is affecting the versus any other virus?
Yeah, it's not actually the, well, it is sort of the meningitis. Let me back up and say it's specifically encapsulated. So what is it about eculizumab and meningitis? It's specifically the encapsulated organism requires MAC or C5b through 9 to help your body fight it. So you need C5b through 9, that terminal complement pathway, to fight encapsulated organisms. That's meningococcus, streptococcus pneumoniae, and Haemophilus. So those are the 3 organisms that you are in general would be at risk for, and those are the ones that we strongly encourage that you're immunized to. The Streptococcus and Haemophilus are not quite as scary, so we'll in general use old immunization, you know, records, if you will, for that. For some people, we pretty much immunize everybody again, but anyway. The meningococcus, not only is it an encapsulated organism that cannot be destroyed easily without your complement system, but it also has it likes to go into the meningeal spaces. So that's why you end up with meningitis when you're on complement blockade. It's the same thing, by the way, with if you have congenital complement abnormality, it's the same thing. You're at risk for this, you know, meningitis. Pseudomonas is not one that we worry about. It's okay. You can, so a lot of times that's another thing you can Google. You can Google encapsulated bacteria, and you probably will come up with those 3. How's our timing? Yeah, we need to wrap up. Sorry, guys. Anything? I'll be around.